Welcome to the deep dive. You sent us your study materials for the OBGYN NBME shelf, and our mission is pretty simple today.
Yeah, we're here to pull out the absolute must-know stuff.
Exactly. The highest yield info, but in a way that actually sticks with you. Think of it as, your shortcut to feeling confident for the exam.
We've got a lot to cover, from the vulva all the way through the postpartum period.
It's comprehensive, so let's dive right in and make this memorable.
Let's do it, starting with the basics, the anatomy.
Okay, anatomy essentials. Let's begin with the vulva. The Bartholin's glands jumped out straight away.
Right, location-wise.
Around the 4 and 8 o'clock positions, sort of tucked away there.
And their function is lubrication. Interestingly, they're homologous to the bulbourethral glands in males.
But the real high-yield part, clinically speaking,
Absolutely, blockages. That's what you need to know.
can lead to a cyst, which might be asymptomatic, no big deal sometimes.
Or it can become an abscess, and that's usually painful.
Right, and the treatment path seems pretty clear.
Yeah, first step is typically incision and drainage. Sometimes a word catheter gets placed to keep it open.
And if it keeps coming back...
Marsupialization is an option, and antibiotics aren't always a given, but you consider them.
Here's a key point, though. Recurrence in postmenopausal women.
Big red flag. You need a biopsy in that case. Rule out carcinoma. That's crucial.
Definitely a must-know distinction. Okay, still in that region, pain relief during delivery.
Pudendal nerve block. It's mentioned for vaginal delivery pain. More localized.
Good targeted approach. Okay, moving inward. The cervix.
The key landmark here.
The squama-columnar junction, also called the transformation zone.
Yes. And why is it so important? Think about the cell types changing there.
It's an active area.
Highly active. Metaplasia is happening constantly. And that's where over 90% of cervical neoplasia originates. Pre-cancers, cancers, this is the spot.
So pap smears, colposcopy, that's the target zone.
Precisely. Got to know the transformation zone.
Makes sense. Okay, heading up into the uterus, there's that classic surgical phrase.
Water under the bridge.
Right. What does that mean anatomically?
The ureter carrying urine, the water, passes underneath the uterine artery, the bridge.
Ah, okay. Definitely critical during surgery, like a hysterectomy, to avoid nicking the ureter.
Absolutely critical. And the uterus itself, familiar parts. Fundus at the top, the main body or corpus, the cornua where tubes enter.
And the cervix at the bottom.
And that muscular wall, the myometrium, has 3 layers.
Outer longitudinal, middle oblique, inner longitudinal.
And that middle oblique layer, the figure 8 fibers, that's really key for contraction during labor and clamping down on vessels afterward.
Ah, preventing postpartum hemorrhage, like a built-in tourniquet.
Exactly. It's a brilliant design, actually.
It really is. Okay, fallopian tubes next. Let's trace the path from the ovary.
Starts with the infundibulum, which has those finger-like fimbria.
To help catch the egg.
Yep. Then comes the ampulla. Remember this one?
Why the ampulla?
Most common site of fertilization. And, clinically,
Ectopic pregnancy.
the most common location for ectopic pregnancy is the ampulla. High yield for sure.
Okay, ampulla. Got it. Then the narrower part.
The isthmus, which is often the target for tubal ligation for sterilization.
And finally, the part that goes through the uterine wall.
The intramural segment.
So, key takeaways. Fertilization, usually in ampulla. Ectopic pregnancy, most common in ampulla. Tubal ligation often targets the isthmus.
You got it. Now, ovaries. Blood supply.
Dual supply. Ovarian arteries coming straight off the aorta.
And branches from the uterine arteries, which come from the internal iliac.
And they connect, right. And anastomosis.
Yeah, which is helpful clinically, provides a bit of redundancy if one supply is compromised, like during surgery.
Good backup system. Okay, let's talk support structures, the ligaments. Round ligament pain pops up a lot.
Classic pregnancy complaint. Sharp pain, often one-sided in the lower abdomen.
Worse with movement, better with rest.
Typically, yes. Management is usually rest, maybe acetaminophen, sometimes a belly band for support.
Then there's the broad ligament, kind of like a sheet.
Exactly. Drapes over the uterus. Contains the fallopian tubes, round ligaments, uterine and ovarian vessels. Lots of structures within it.
What about the IP ligament?
Infundibulopelvic ligament. That's the one carrying the ovarian artery and vein to and from the ovary.
And the round ligament itself, where does it go?
Starts near the uterine cornua, travels through the inguinal canal, and ends up in the labia majora.
Okay, another surgically important one, the cardinal ligament.
Also called the Mackenrot ligament. Runs from the cervix out to the pelvic sidewalls.
And the danger here.
The ureter runs very close by. Again, risk of injury during hysterectomy when clamping this ligament.
Ligaments are key surgical landmarks. And speaking of hysterectomy, they often start by ligating the round ligaments.
That's a common first step, yes. Ligate and divide the round ligaments.
Good to know the sequence. Okay, down to the pelvic floor. Pelvic organ prolapse. What's the underlying issue?
Usually a defect or weakness in the pelvic diaphragm muscles, those muscles that provide support.
An episiotomy cuts the perineal body.
Correct. That central wedge of tissue between the vagina and the anus.
Last anatomy point. Pelvic shapes.
Gynecoid is considered the ideal shape for vaginal birth. More rounded inlet.
And the ischial spines.
Key landmarks. Xerostation. Tells you how far the baby's head has descended into the pelvis during labor.
Phew. Okay, that's a solid anatomy foundation. Extremely important stuff.
Absolutely, it underpins everything else.
Right. Now let's shift gears to diagnosing pregnancy. We have those categories of signs.
Presumptive, probable, and positive.
Presumptive are the subjective ones, like nausea, feeling tired, breast tenderness, things the woman notices.
Exactly. Probable signs are things the clinician observes, like Hagar's sign, that softening of the lower uterus, or a positive pregnancy test.
But not definitive yet.
Right. Positive signs are the undeniable proof.
Seeing the fetus on ultrasound, hearing the heartbeat, examiner feeling fetal movements.
Can't argue with those.
How about calculating the due date, EDD?
Nagel's rule is the classic method. First day of the last menstrual period, add 7 days, subtract 3 months, add a year.
Simple enough, assuming the LMP is reliable.
That's the key assumption.
Yeah.
We also mentioned cervical changes.
Yeah, non-pregnant cervix feels firm, like the tip of your nose.
Right. And a pregnant cervix softens up, feels more like your lips. Hagar's sign is part of that softening.
Good comparison. And fundal height, how does that track?
It's a useful estimate of gestational age, especially between 20 and about 36 weeks.
At 20 when it's usually right at the umbilicus.
Typically, yes. Then it grows about 1 centimeter per week after that, roughly. Your source probably has a table, like Table 2.1, showing the progression.
Good clinical marker. Now let's talk about HCG, human chorionic gonadotropin.
The pregnancy hormone. It's a glycoprotein made by the developing placenta, specifically the trophoblast cells.
It has 2 subunits, alpha and beta.
Right, the alpha subunit is similar to LH, FSH, and TSH, but the beta subunit is unique. That's what the tests usually pick up.
And its main job early on.
Crucial role. Maintains the corpus luteum for the first, say, 7 weeks or so.
So the corpus luteum keeps making progesterone.
Exactly, and progesterone is essential to sustain the early pregnancy until the placenta takes over production.
How do the levels change?
They rise rapidly. Typically double about every 48 hours in a normal early intrauterine pregnancy before 10 weeks. Then they peak around 10 weeks and gradually decline.
When can we detect it?
Pretty early, in blood or urine, maybe 6 to 12 days after fertilization.
In abnormally high levels, what could that suggest?
Could be a molar pregnancy, hydatiform mole, choriocarcinoma, multiple gestations, or sometimes even other types of tumors.
Okay. And there's a link between HCG levels and ultrasound findings.
Yes, the discriminatory zone. Usually, once HCG levels reach about 1,500 to 2,000 MIU/mL, you should be able to see a gestational sac within the uterus on a transvaginal ultrasound.
So if HCG is above that level, but you see nothing in the uterus?
You have to strongly suspect an ectopic pregnancy. Very important correlation.
Makes sense. We have urine tests and blood tests for HCG.
Urine tests are common for initial diagnosis. First morning urine is best, most concentrated, usually sensitive enough by about a week after a missed period. False negatives and positives can happen, though.
And blood tests. Plasma HCG.
Those are quantitative. They give you an actual number. Not usually routine for diagnosis, but very useful for tracking levels over time.
Like in cases of first trimester bleeding.
Exactly. Serial quantitative HCG levels are key there.
Oh.
If they aren't rising appropriately, it suggests a non-viable pregnancy, maybe an impending miscarriage or an ectopic.
Okay, vital tool. Moving on to direct fetal assessment, heart rate.
Fetal heart rate, or FHR. You can usually pick it up with Doppler around 10 to 12 weeks.
And the normal range.
Generally 110 to 160 beats per minute.
Good baseline to know. And then there's ultrasound.
Ultrasound is huge in OB. So many uses.
Like confirming it's actually in the uterus, an IUP.
Right. Checking viability, seeing cardiac activity, usually when the embryo is bigger than 5 millimeter. Dating the pregnancy accurately, especially early on.
Identifying twins or more.
Yep. Multiple gestations. And later, screening for fetal anomalies.
Are there limitations?
Sure. Dating accuracy decreases after 20 weeks because fetal growth varies more then, and sometimes image quality can be tough with increased maternal BMI.
What's the routine use in a low-risk pregnancy?
Typically a first trimester scan for dating and neutral translucency if doing that screening, and then a detailed anatomy scan around 18 to 20 weeks.
And generally, ultrasound dating beats LMP dating for accuracy.
Especially first trimester ultrasound. It's considered more reliable than relying just on menstrual dates, which can be uncertain.
Okay, excellent overview of diagnosis. Let's dive into antepartum care highlights.
All right, some key definitions first. Gestational age versus developmental age.
Gestational age starts from the first day of the LMP.
Right. Developmental or embryonic age starts from fertilization about 2 weeks later. Important distinction.
Trimesters.
First is up to end of week 12. Second is 13 to end of week 27. Third is 28 weeks until delivery.
Embryo versus fetus.
Embryo up to 8 weeks post-conception, then it's called a fetus.
In terms like previable, paraviable, preterm term.
Previable is generally before viability, maybe 22 weeks. Paraviable is that cusp, around 22, 24 weeks, where survival is possible but difficult. Preterm is 20 weeks up to 36 and 67 weeks. Term is 37 weeks to 42 weeks.
Got it. Reproductive history, gravidity, and parity.
Gravidity, G, is just the total number of pregnancies, regardless of outcome.
And parity, P, often that FTAL system.
Yeah, FPL is common. F for full-term births, 37 plus weeks. P for preterm births, 20, 36 weeks. A for abortions, spontaneous or induced, 20 weeks. And L for living children. Helps summarize outcomes.
Okay. How often are prenatal visits?
Frequency increases, usually monthly early on, then every 2 weeks later in the second trimester, then weekly towards the end.
And that first visit is a big one.
Super comprehensive. Detailed history, biographical, past OB stuff like delivery types and complications, menstrual contraceptive medical history, full physical exam, baseline labs, establish the EDD, and lots of patient education.
Especially those danger signs to watch out for.
Absolutely crucial. Things like bleeding, fluid leaking, severe headaches, vision changes, decreased fetal movement.
We mentioned fundal height before, correlating with weeks between 20 and 36.
Yep, it's a good screening tool for growth. If it's way off, you investigate further. Could be dating issue, fibroids, twins, growth restriction, polyhydramnios.
Makes sense. Fetal surveillance, usually third trimester for higher risk situations.
Right. Tools like the non-stress test, the NST.
What are we looking for on an NST?
We want a reassuring pattern. A normal baseline heart rate, moderate variability, which shows the nervous system is working well.
And accelerations.
Yes, those temporary increases in heart rate. We want to see at least 2 accelerations of 15 beats above baseline, lasting 15 seconds, within a 20-minute period. That makes it reactive.
What about decelerations?
We don't want to see concerning ones, like late decelerations or deep, prolonged variable decelerations.
Okay, so a reactive NST is good news. What about the CST, contraction stress test?
That one tests how the baby handles contractions. Yeah. You would do some mild contractions, usually with oxytocin or nipple stimulation, and watch the FHR response.
What's a good result?
A negative CST is reassuring, means no late decelerations occur with the contractions. A positive CST with late decels is concerning for uteroplacental insufficiency.
Got it. Then there's the BPP biophysical profile.
Right. That combines an NST with an ultrasound assessment.
Looking at what on ultrasound?
4 things: fetal breathing movements, gross body movements, fetal tone, and amniotic fluid volume.
And you score each one.
Yep, 0 or 2 points for each of the 5 components, NST plus 4 U.S. markers. A score of 8 or 10 out of 10 is generally considered normal.
And the modified BPP.
That's simple, or just the NST plus the amniotic fluid index, or AAFI from the ultrasound. Quicker screen.
Okay, screening for anomalies. Lots of options now. cfDNA.
Cell-free DNA. It's a blood test for the mother, usually done after 10 weeks. Screens for common trisomies like 21, 18, 13, and sex chromosome issues.
How good is...
Very high sensitivity, especially for Down syndrome, trisomy 21, particularly in higher risk populations. It's a screening test, though, not diagnostic.
Right. First trimester screen.
Done between 11 and 13 weeks. Combines an ultrasound measure, the neutral translucency, NT.
That fluid at the back of the neck.
Exactly. Plus, maternal blood test for PPPA and free beta-HCG. Patterns in these can suggest risk for Down syndrome and other aneuploidies.
Then later in pregnancy, the quad screen.
Usually 15 to 21 weeks. It measures 4 things in maternal blood: UE3, AFP, HCG, and Inhibin A.
Screens for Down syndrome and also neural tube defects.
Yes, based on the pattern of the results. But remember, incorrect dating is a really common cause of an abnormal quad screen result. Always check the dates.
Good point. And AFP specifically, MSAFP.
Maternal serum alpha-fetoprotein. Main role is screening for open neural tube defects like spina bifida. Levels normally peak around 32 once. If it's high or low, needs further investigation, often with detailed ultrasound.
And nowadays, genetic screening is offered to everyone.
Yes, current guidelines recommend offering screening and diagnostic testing options to all pregnant patients, regardless of age or risk factors.
If screening is positive, or for other reasons, diagnostic tests are needed. Amniocentesis.
Usually done between 15 and 20 weeks. A needle goes through the abdomen into the amniotic sac to get fluid containing fetal cells for genetic testing.
Risks.
Small risk of procedure-related fetal loss, maybe around 1 in 1,000 now, with ultrasound guidance.
And the other option? CVS.
Chorionic villus sampling can be done earlier, 9 to 12 weeks typically. Takes a sample of placental tissue, chorionic villi.
Risk compared to amnio.
Slightly higher risk of fetal loss, maybe 1 in 500. But you get results earlier in the pregnancy.
Okay, choices to discuss with patients. Let's talk nutrition. Needs go up.
Definitely. Need more calories, more protein. Folic acid is absolutely critical, especially preconception and early pregnancy, to prevent neural tube defects.
And the dose is higher if there's a history of NTD.
Much higher, yes. Iron needs also increase significantly. Supplementation is often needed to prevent anemia. Calcium and zinc are important too.
What about vegetarians?
Need careful planning to ensure enough protein, iron, B12, calcium, and zinc. And watch out for pie. Craving non-food items like ice or clay can signal deficiencies.
Makes sense. We should briefly mention common discomforts.
Yeah, things like nausea, vomiting, morning sickness, heartburn, constipation, backache, that round ligament pain we discussed, all very common. Management strategies exist for most.
Exercise, travel.
Generally encouraged with modifications. Avoid high-impact or risky activities. Travel is usually okay, especially in the second trimester, but check airline policies and consider DVT prevention on long trips.
Immunizations are key too.
Absolutely.
Yeah.
Tdap vaccine in every pregnancy, usually third trimester, protects the baby against pertussis. Flu shot is recommended too.
But avoid live vaccines.
Correct. No MMR or varicella during pregnancy.
And reiterating those danger signs is crucial.
Always. Bleeding, leaching fluids, severe headache, vision changes, reduced fetal movement, regular painful contractions before term, call the provider immediately.
Okay, solid antepartum overview. Now let's get into labor and delivery, the intrapartum period.
The main event. Yeah. Divide into 3 stages.
First stage is cervical change.
Yep. Starts with regular contractions causing cervical dilation and effacement. Ends when the cervix is fully dilated at 10 centimeters. Has latent and active phases.
Second stage.
Pushing. From full dilation until the baby's born.
Third stage.
Placental delivery. From the baby's birth until the placenta comes out.
Important to know true versus false labor.
Definitely. True labor contractions get stronger, longer, closer together, and cause cervical change. Usually felt in the back and radiate around, not relieved by rest.
False labor, or Braxton Hicks, are more irregular.
Irregular, don't intensify consistently, often felt just in the abdomen, and don't change the cervix. Usually ease up with rest or hydration.
How do we assess someone in labor? History first.
Key question. Have your membranes ruptured? Status of the water breaking.
In confirming rupture of membranes, ROM.
Look for pooling of fluid in the vagina on speculum exam. Check for ferning the fluid dries in a fern-like pattern on a slide. And the nitrazine test amniotic fluid is alkaline, turns the pH paper blue.
Then the cervical exam. What are we checking?
4 things, mainly dilation, 0-10 centimeter, effacement, thinning, 0-100%, station, how low the baby is relative to ischial spines, MACA3 to +3 or MEGA5 to +5, and also consistency and position of the cervix.
And the Bishop score.
That combines those factors to predict how likely a labor induction will be successful. Higher score means more favorable cervix.
How about assessing the baby's position?
Leopold maneuvers.
Better?
It's 4 abdominal palpations.
To figure out lie, presentation, position.
Exactly. Lie is usually longitudinal. Presentation is ideally vertex, head down. Position tells you where the back of the baby's head is relative to the mother's pelvis, e.g. occiput anterior.
Vertex is normal. What are malpresentations?
Breech, bottom or feet first, is the most common. Face presentation, mentum anterior or posterior is rarer. These can complicate delivery.
Then there are the cardinal movements of labor. The baby's dance through the pelvis.
Right. Engagement, descent, flexion, chin tucks, internal rotation, head turns, extension, head delivers, external rotation, head turns back, and expulsion, body delivers.
Each step helps the baby navigate the pelvic shape.
Precisely. It's a mechanical process.
Managing a normal vaginal delivery, key steps.
Control the head delivery, check for neutral cord, guide the shoulders out, anterior then posterior, deliver the body, clamp and cut the cord, eventually deliver the placenta.
How do you know the placenta is separating?
Signs like a gush of blood, the cord seems to lengthen, and the uterus becomes firmer and rises in the abdomen.
Okay. Monitoring during labor is crucial. Contractions.
Moderate frequency, duration, intensity. Can use external tachotonomometer or an internal uterine pressure catheter, IUPC, for more precise measurement, especially if labor isn't progressing. That gives you Montevideo units.
And fetal heart rate monitoring.
Continuous electronic fetal monitoring is common, especially in higher-risk labors. We look at baseline rate, variability.
Variability is important, right? Shows oxygenation.
Good variability. Moderate is reassuring, suggests adequate oxygenation and a healthy nervous system. Minimal or absent variability is concerning. Marked variability can also be seen.
Accelerations are good.
Yes, usually indicate fetal well-being.
Decelerations, the different types.
Early decelerations mirror contractions caused by head compression, usually benign. Late decelerations start after the contraction peak, indicate potential uteroplacental insufficiency. Baby might not be getting enough oxygen. That's concerning.
And variable decelerations.
Abrupt drops, often V-shaped, usually due to cord compression. Can be mild or severe depending on depth and duration.
We also watch for tachycardia or bradycardia.
Right. Baseline 160 is tachycardia, 110 is bradycardia. Both need evaluation. And a sinusoidal pattern is rare but ominous, often linked to severe fetal anemia.
And these patterns get categorized.
Yes, into Category 1, normal, reassuring. Category 2, indeterminate, needs continued surveillance, maybe intervention. And Category 3, abnormal, predicts abnormal fetal acid-base status, needs prompt action.
What if labor isn't progressing normally? Abnormal patterns.
Protraction disorders, slow progress, or arrest disorders, no progress. Often think about the 3 Ps.
Power, passenger, pelvis.
Exactly. Is the power contractions adequate? Is the passenger baby-sized position favorable? Is the pelvis shape size adequate? Need to assess all 3.
Sometimes labor needs a nudge. Induction.
Starting labor artificially. There are specific indications of maternal reasons, like preeclampsia, fetal reasons, like growth restriction, or obstetric reasons, like post-term. Table 5.7 in your source likely lists them.
Contraindications too.
Sure. Things like prior classical C-section, placenta previa, active herpes.
Methods for induction.
If the cervix isn't ready, low Bishop score, use cervical ripening agents first, like prostaglandins, misoprostol, dinoprostone. Then, or if the cervix is favorable, use oxytocin, pitocin, the third trip, to stimulate contractions.
Risks with oxytocin.
Main risks are uterine tachysystole contractions too frequent or strong, which can stress the baby, and with prolonged use of high doses in hypotonic fluids, water intoxication.
Okay. Sometimes vaginal delivery isn't possible or safe. Cesarean delivery.
Indications are numerous labor arrest, fetal distress, Category 3 tracing, malpresentation like breech, placenta previa, prior classical C-section, etc.
What about TLEC, trial of labor after cesarean?
An option for some women with a prior low transverse C-section allows them to attempt vaginal birth.
Main risk.
Uterine rupture at the site of the prior scar. It's rare but serious. Careful candidate selection and monitoring are essential. Not everyone is a candidate.
Sometimes a little help is needed at the end. Operative vaginal delivery.
Using forceps or a vacuum extractor to assist with the birth during the second stage. Specific indications like prolonged second stage or suspected fetal compromise. Also specific contraindications and potential risks to both mother and baby.
And pain control options.
Lots of choices. Pudendal block for perineal anesthesia right at delivery. Epidural is very common medication infused into the epidural space for broader pain relief.
Epidural downsides.
Can cause maternal hypotension, fever, sometimes prolonged second stage slightly, requires monitoring. Spinal anesthesia provides faster, denser block, often used for C-sections. General anesthesia is usually reserved for emergencies.
Great overview of interpartum. Let's finish with postpartum essentials.
The puerperium, or the 4th trimester, lasts about 6 weeks. Body's returning to the non-pregnant state.
Uterine evolution.
Uterus shrinks down. Fundus descends about 1 centimeter per day, back in the pelvis by about 2 weeks. Lochia is the vaginal discharge, starts bloody, rubra, becomes pinkish, serosa, then yellowish white.
Alba. Cervix and vagina change too?
Yep, gradually regain tone, cervix closes, vagina returns to near pre-pregnancy size.
Urinary tract changes.
Marked diuresis, peeing a lot in the first few days to get rid of extra fluid. Increased risk of UTI due to potential bladder hypotonia or catheterization.
Blood changes.
Hematocrit might drop slightly, then rise. Coagulation factors remain elevated for a while, increasing VTE risk, gradually normalize.
Routine postpartum care involves what?
Monitoring vitals, fundal height, lochia, perineum immediately after birth, pain management, encouraging ambulation, support with breastfeeding or infant feeding, discharge teaching.
Postpartum infections are a major concern. Endometritis.
Infection of the uterine lining. Big risk factor is C-section. Others include prolonged rupture of membranes, internal monitors,
The symptoms.
fever, uterine tenderness, fundal tenderness, foul-smelling lochia. Treatment is usually broad-spectrum IV antibiotics like clindamycin and gentamicin.
UTI is also common.
Yes, dysuria, frequency, urgency, diagnose with urinalysis and culture, treat with antibiotics.
A wound infection.
Can happen at C-section incision or perineal laceration episiotomy site. Look for redness, swelling, discharge, increasing pain. Management depends on severity, might need opening, drainage, antibiotics.
Discharge instructions are key warning signs again.
Absolutely. Fever 100.4 F38C. Heavy bleeding, soaking more than a pad per hour, foul lochia, severe pain, leg swelling or pain, DVT sign, chest pain, shortness of breath, PE sign, persistent depression symptoms.
When can intercourse resume? Contraception.
Usually advised to wait about 6 weeks or until perineum healed and bleeding stopped. Contraception is crucial. Ovulation can return quickly, even before periods resume, especially if not exclusively breastfeeding.
Options.
Progestin-only methods, pills, implant injection, IUD, are safe immediately and with breastfeeding. Combined estrogen-progestin methods, pills, patch, ring, usually delayed a few weeks, especially if breastfeeding, due to theoretical effects on milk and increased VTE risk early on. Lactational amenorrhea method, LAM, is effective only if specific criteria are strictly met.
Important discussion. Infant care before discharge?
Newborn exam, hearing screen, metabolic screening, newborn screen, first hepatitis B vaccine dose, vitamin K shot.
Breastfeeding physiology.
Prolactin from the pituitary stimulates milk production. Oxytocin causes milk ejection or letdown reflex triggered by infant suckling.
Benefits are numerous.
Huge benefits. For baby, nutrition, immunity, antibodies, GI maturation. For mother, helps uterine involution, bonding, potentially reduces risk of some cancers later.
Contraindications.
Some maternal infections like active untreated TB or HIV in resource-rich settings. Certain medications are unsafe. Illicit drug use. Infant galactosemia.
Finally, postpartum psychiatric issues.
Really important area. Postpartum blues are super common. Tearfulness, mood swings in the first week or two, usually resolve on their own. Self-limited,
Postpartum depression.
more severe, lasts longer, beyond 2 weeks, affects functioning. Symptoms like persistent sadness, anxiety, guilt, changes in sleep appetite, thoughts of harm. Needs screening like Edinburgh Postnatal Depression Scale, and treatment therapy, medication.
And postpartum psychosis.
Rare, but a psychiatric emergency. Rapid onset of delusions, hallucinations, disorganized thoughts, often related to bipolar disorder. High risk of harm to self or baby. Requires immediate psychiatric hospitalization.
Postpartum thyroid issues, too.
Can happen. Postpartum thyroiditis can cause transient hyperthyroidism followed by hypothyroidism, or just one phase. Need to monitor thyroid function if symptoms arise. Fatigue, palpitations, weight changes, mood changes. Usually resolves, but can become permanent hypothyroidism sometimes.
Wow. Okay. That covers the main postpartum points.
A lot happens in that 4th trimester.
So there you have it, a pretty focused deep dive hitting those high-yield concepts for your OBGYN shelf exam prep. We went from anatomy all the way through postpartum.
Yeah, the goal was really to pull out the core information, the things that are most likely to show up and are fundamental to understanding the specialty. Hopefully framing it this way makes it more memorable.
We definitely encourage you to go back to your study materials now, maybe with this framework in mind. See how these key concepts connect all the dots.
Absolutely, because in practice and on the exam, these topics aren't isolated. It's all interconnected. Understanding the anatomy helps you understand labor, which helps you understand potential postpartum complications.
And if any particular area we touched on still feels a bit shaky for you,
That's your cue. That's where you should focus some extra study time. Use this as a guide to prioritize your efforts.
this deep dive should give you a really solid base.
Definitely build on this foundation, keep reviewing, and you'll be in good shape. We really wish you the very best of luck with your exam prep and the exam itself.